Good evening, everyone. Welcome. Welcome to our live telephone town hall meeting with the Texas Medical Association. Tonight's conference call is going to discuss important legislative issues for medicine in the upcoming state legislative session that is going to begin in January of 2019. So just over the horizon here. In just a moment, I will be introducing Dr. Diana Fite, who will be serving as our physician host for the evening. She is the chair of the Texas Medical Association Board of Trustees, and she will begin her opening remarks here shortly. We're going to be having several live polling questions this evening that we're going to need your input on. And with that, it is my great privilege to introduce Dr. Diana Fite, who is the physician host for this evening. Dr. Fite is the chair of the Texas Medical Association Board of Trustees. Dr. Fite, thank you so much for taking time out of your schedule to join our event tonight.
Thank you, Jason. Good evening, everyone, and welcome to this Texas Medical Association telephone town hall meeting on legislative priorities for medicine as we approach the 2019 session of the Texas Legislature, which convenes in January. This is the last in a series of 5 area TeleTown halls that the TMA has hosted. At this time, it is my pleasure to welcome the TMA President, Dr. Doug Curran. Dr. Curran is a family physician with UT Health East Texas and Lakeland Medical Associates in Athens, Texas. He graduated from the University of Arkansas for Medical Sciences and completed his residency in Fort Worth. Dr. Curran has spent 42 years advocating for the patients and physicians of Texas. Welcome to the call, Dr. Curran.
Thank you, Diana. It's always good to be together with fellow physicians and visit about our opportunities in the next legislative session. You know, our medical society is the largest and strongest in the nation. We support 51,000 physicians and medical students, and you know, we're made up of 112 component medical societies, and we worked really hard to establish priorities in legislation, and we've been very influential in changing things at the legislature. Physicians are huge economic drivers in our state, and as everyone knows, as we watch what's going on in the election cycle, a lot of focus on economic drivers and what's happened in the economy of Texas. And it's important for us to remember that we have 52,550 physicians that are involved in patient care in Texas. And those physicians employ 670,000 people. The average number of jobs that a physician creates is 13.1. And the total output of the economy generated by physicians is $118 billion. And that kind of compares with the higher education at $10.9 billion, and legal services $43.5 billion, and home health at $22.4 billion. So we see we really have a lot of skin in the game, and we make a big difference in Texas. And I'm excited we're going to get to talk about some of these issues. And I'm glad to be with you this evening, Dr. Fite.
Thank you, Dr. Curran. Next up is Dan Finch, the TMA Director of Legislative Affairs, who acts as the traffic cop to keep things moving for tonight's TMA TeleTown Hall on the 2019 legislative session. Dan.
Dr. Fite, thank you very much for your introduction. I am a traffic cop, or actually more like conductor on the train, and it's my job to make sure the train runs on time and not let Dr. Curran run it off the tracks a little bit. This is our 5th and last TeleTown Hall, and before we get started, I need to lay out a couple of ground rules for all the folks who are on the call. We're going to cover an awful lot of ground in a short period of time, and generally in 4 areas: the budget, Medicaid, GME, and maternal health insurance issues, public health issues, then licensure and other issues that we anticipate into 2019. With that behind us, let's move into some of the substance of the call tonight. Dr. Curran, as always, it's a delight to be with you and talk, as we have for years, about Medicaid and the budget and all that goes around that.
Yeah, well, as you know, Dan, the only thing that the legislature really has to do is pass a budget. and a big portion of that budget is Medicaid.
And perhaps one year that won't be all they do.
That's right. And this may be the year that all they do is the budget, but probably not. And but as we move forward, you know, the Medicaid's always a big issue because it's one of the biggest features in the budget. And as usual, it's going to be an issue this year. And I heard the governor say in his debate that he was not in favor of expanding or modifying any entitlements, and so I think it'll be a lift again this year. But I'm also confident it's time to do something.
Sure.
And it's time for a TMA to push up and see some improvement in payment. It's been 2 decades since we've had any change in payment in Medicaid, and it's time to request an adequate payment and see physicians paid appropriately for what they're doing.
Yeah, and I think the reality is in the last 20 years we've had one increase, and that was due to a lawsuit that was settled in 2007, and it was a marginal update in fees. And then, of course, the first 2 years of the Affordable Care Act, we had federal dollars to bump primary care payments up to a Medicare level, but of course that fell back.
And we know that saved money, and so leveraging some of that information as well as just the fact that there's not much access to care in the current environment. If we want to get more physicians involved, we're going to have to pay better. And
let me ask you, Dr. Kern, it was just last week that sort of a landmark meeting. TMA and the Texas Hospital Association, along with the Texas Association of Health Plans, had a Medicaid summit. Talk about some of the issues that you all discussed and the joint efforts that we'll make with those organizations going forward.
That's correct, Dan. We had a really good meeting. Everybody was there, and there was a lot of communication and a lot of options out there for things that we can do that are positive. And we talked specifically, made some recommendations out of that in regard to maternal health. And those recommendations came directly out of the Congress that TMA held in March. And that Congress, we made some specific recommendations about appropriate prenatal care and taking better care of our moms. We know that our numbers have not been good, and in a state where the economy is booming, we've got to take better care of our people. And so we as a group, Hospital Association, TMA, and the healthcare plans have agreed to move forward all those issues in regard to maternal health. And that would include a full year after delivery of care, and that's going to make a huge difference in the ability to get appropriate management of patients that are at risk.
Yeah, I think currently right now almost 55% of the births in the state of Texas are Medicaid.
Exactly.
2/3 of Medicaid enrollees are moms and kids. The moms go on the program, but right now the program limits them only to 60 days of coverage, and that's can be a huge factor in their health care and ultimately in extending that will help address problems related to maternal.
Yeah, well, we know that moms are at risk during that first year afterwards. So just increasing availability of services and care is going to make an enormous difference in outcomes.
Yeah, the other, of course, when we're talking about the budget, and that covers such a wide range of issues, but we're also looking at graduate medical education. And we've been really involved in budgeting and in securing appropriations for GME programs for the last number of years, quite successfully. But still, we set our goal, in fact, to have in legislation last year that the state has to achieve a ratio of 1.1 first-year residency slots for every graduating medical student, and that's so that we can continue to train the next generation of Texas physicians. But we're talking about adding 3 new schools and expanding enrollment in the others. So
if we're going to add new schools, Dan, we got to have more residency slots, or we're wasting Texas money. I mean, we're seeing it costs a significant amount of money to educate our medical students. And medical schools are economic drivers, so a lot of people are interested in seeing a medical school in their area, but the reality is if we don't have residency slots, then we got problems. And I'm living proof of how that works. You know, Dan, I trained at the University of Arkansas Medical School, and then I came to John Peter Smith in Fort Worth and did my residency, and I practiced for 39 years in Athens, Texas, which is 120 miles from Fort Worth. So that's how it works. docs stay where they train, where
Absolutely.
they do their residency.
You know, it's ironic because it's as true today as it was a generation ago that 80% of you end up within 100 miles of where you train, and that doesn't, you know, that holds up if you train at John Peter Smith in Fort Worth or Texas Tech in El Paso or the new Rio Grande Valley, UT Rio Grande Valley. It's got, but there are significant challenges moving ahead in terms of securing commitments for these programs to continue to fund.
Yeah, we're going to have to work at both the state level and the federal level because federal funding is just all messed up. And they're funding states at the same level they did in the 1990s, and we haven't changed that mechanism of funding. So we're going to have to continue to work on that because our state's a growing state. Shrinking states are getting the same money they got years ago, and our growing states get the same money it got years ago. That's just not okay. We've got to fix that disproportionate behavior so we can appropriately educate our young physicians.
Really good point. I know that in 2002, 2003, we were licensing on average about 2,200, 2,300 physicians a year. Last year, we licensed over 5,000. But Texas is a fast-growing population, I think, as you know. And we're making headway, but we're not growing fast enough. How do we attract and how do we organize particular residency programs related to primary care? Because that's such a significant need moving forward. You're an old family doc, you know this.
That's really true. I think the secret sauce to really making the healthcare system a lot better is to be sure that those primary care residencies are adequately funded and are established in such a way that we can get physicians out on the front lines. And as a result, we'll see a huge difference. A good example is the alternate payment model that the city of Fort Worth is using. That was in the paper this weekend. And it's really a great model, and it saved the city of Fort Worth about $4 million for their 18,000 employees. And I think those are the kind of things that we got to work on to make sure they happen. But in regard to new models of payment, we got to be sure we get adequate payment for that because it's a lift to get those things established, up and running, and doing the things you want to. And you got to have good primary care docs to make that happen.
Sure, I understand. But it also means that there's an increasing involvement of the legislature.
Right.
And at least seeding some of the money for graduate medical education and maintaining that commitment to growing GME as we grow medical school enrollment and schools.
Yes. It has to go hand in hand. It just has to.
You know, without a doubt. Let's pause for a second. Jason, I'll ask you to read our first poll question. And doctors, you may use your phone to answer this poll question.
We are going to be starting our first polling question right now. Again, you can, like Dan said, you can answer these by pressing numbers on your telephone keypad. We're asking you and our listening audience, what do you believe Texas must prioritize to build the physician workforce? Press 1 on your telephone keypad if you think we need more medical school capacity. Press 2 if you believe we need more GME capacity. Press 3 if you believe the answer is both. Press 4 if you believe the answer is neither. And press 5 if you're undecided. Back to you, Dan.
Great. Thank you, Jason. And while we're waiting for your responses to tabulate, I'm pleased to call on Dr. Rob Rogers, who is chairman of the TexPAC Board of Directors. TexPAC is the political action committee of the TMA, and it's been a very busy year and a very intense involvement in elections, both primary and general around the state. Dr. Rogers, are you there?
I am here, Dan. Thanks very much.
Thank you for joining us.
Sure. Well, as you know, TexPAC, as usual, has been very active in analyzing candidates, looking at voting records, looking at campaigning, and we are in the midst of our early voting now, and I think everyone is probably aware that we're seeing record numbers of voters for a midterm election. So we're excited about that. I want to emphasize to our listeners that TexPAC's success is in a large part dependent on the involvement of the local physicians. We have local physicians doing candidate interviews. Any local physician that will work on a campaign is highly valued by the candidate, and this becomes a very important issue when we make our visits during First Tuesdays during the session. We'll continue early voting through October 22nd, and then Election Day is November 2nd, and it will be very exciting to see how things turn out.
Great. Dr. Rogers, thank you for joining us. We really appreciate it. And so as we look at the poll questions, it's not surprisingly, nearly half of you at 45% say that we need both medical school capacity and GME. 27% say more GME capacity, and 12% say more med school capacity. These are perennial issues for TMA, and they will be again in 2019. We have Dr. Anthony Noya from Georgetown on the line who has a question about increasing primary care positions. Dr. Noya, are you there?
Thanks for taking the call. The reason why I'm calling, or the question I have, is what kinds of things are the TMA doing to increase primary care workforce? As a primary care clinician, I see it all the time. We have great candidates come through in med school, in our programs, and they seem to get enticed into other specialties, mostly due to pay and quality of life issues. I know things are interesting in terms of direct primary care being a way to improve quality of life, but what kinds of things is TMA working on to increase primary care incentives to get our workforce increased?
Thank you, Dr. Noya. Dr. Curran,
yeah,
you're a primary care guy.
Well, I really appreciate that question, because I think it's really an appropriate question, because if you want people to go into primary care, I think we have to offer some attractive features, or they're not going to. And that means a good work environment, that means adequate payment for what we do, and that means a relationship that you can feel valued. And I think sometimes primary care is undervalued, and some people would say it can be done by physician extenders and other things, and we know that's just not true. We know that there's an enormous value in primary care, and I would point you toward what's going on in Fort Worth right now in the value-based care arena with primary care physicians leading that charge, and they've saved the city of Fort Worth about $4 million on their 18,000 employees. Things like that are going to see some real improvement in the payment for primary care because of their value. And I think it also points out we must work really hard to be sure that we get adequate payment for Medicaid, especially in rural Texas, where you're taking care of a lot of Medicaid, and down on the border area and the Laredo area, all those places are taking care of a lot of Medicaid patients, and we have to get adequate payment for Medicaid so that primary care can survive. So I think there's just a whole bunch of features that we're working on, but first and foremost is to value primary care, to be sure primary care is adequately paid, and then to be sure that we're looking at new models of payment where we're paying for performance, we're paying for outcomes, we're paying for saving money, and that ought to be primarily going to the primary care group.
Great. And I think we also look at other models of residency training, not necessarily facility-based, but more community-based, in order to attract and train the next generation of family docs
Absolutely.
in the state of Texas. We're going to take one more question on Medicaid before we move on. Dr. Lucia Williams from Jacksonville, Texas. Dr. Williams, are you there?
Yes, sir, I am. My question is, why hasn't TMA done more to advocate for drawing down more Medicaid dollars from the Medicaid expansion so that more Texans can be covered? Texas is the highest uninsured rate in the nation. Why haven't we advocated for that?
Fair question. Dr. Kern?
Well,
I know this is a pet issue of yours for the last 4 years.
Yeah, this has been an issue that I've been very passionate about, and I feel very strongly about. And I want you to know that back when those dollars first became available, our House of Delegates voted over 70% to seek those dollars, and we have consistently reached out and tried to get those dollars, and we've sought them with great effort, but we reach a lot of difficulty when we start talking that these things are coming out of the Affordable Care Act, and we have met significant obstruction. It's just a non-starter for a lot of the Republican arena that we've had to work in over the past few years. And that's not, it's just the reality of where we are. So I think what we've been trying to do is to try to draw those dollars down through a different source or through a different direction. If we can pull them down through a waiver process through CMS or some other way, but we need to draw down every federal dollar to Texas to help our working poor, to help our population that just does not have adequate health care. And you're so right in that there's something wrong with us if we don't address this, and I think we have that opportunity during this legislative session to do something about our uninsured and our working poor, and we're going to do everything we can here at TMA to make sure our patients get care.
Yeah, we've gone so far as to try to repackage expansion to call it a Texas plan for the working poor, to model it along the lines of a CHIP program with a sliding scale of participation. It's been an uphill battle all the way, and you're right about the waiver programs. And I think part of our challenge moving forward is to see if we can't increase the waiver monies available to us that will go to physician-directed programs because those tend to impact patient care more directly than others.
And a positive note is that we have seen the governor and others be encouraged by some of the plans that are out there. The Indiana plan, he had indicated he was positive about that and how it works. So I think there's opportunity. We just have to see how this session goes, but we're going to be seeking those federal dollars.
Sure. Let's move on because it's somewhat of a related issue, of course, moving from Medicaid to insurance. Private insurance, commercial insurance, and some of the issues we face there. And of course, over the years, it's been contracting, it's been network adequacy issues, and the trends that we see towards more narrow networks and how that impacts both patient access to care. It certainly impacts on balanced billing, out-of-network care, and the ability of physicians to balance bill. We are constantly embroiled in these issues during the sessions.
Yeah. You know, Dan, payment especially, I see insurance companies trying to drive down our payment as low as they can because a bunch of us are still taking Medicaid because we have to. So they just keep driving down our payment as much as they can. And I think we have to demand adequate and appropriate payment so that physicians can adequately manage their practices or contribute to an integrated network if they're a part of that. So we got to have adequate physician payment from insurance companies. And we got to have adequate networks. We know that they squeeze these networks down so much that you can't get in, and as a result of not being able to get in, they keep the money and the money's not spent. So adequate networks are strategic, and we've got to demand that. We've got to be sure that happens.
I know that years ago we fought real hard for an expedited credentialing bill so that when you added a partner to your practice, that new physician to your practice would expeditiously and automatically be on the plan. But we see a lot of problems with that in the last number of years, and the folks in plans that ignore that sort of expeditious credentialing.
Credentialing is still a huge problem.
Sure.
As you know, we just have a new pediatrician in our group, and she's the only pediatrician in our county. And we've spent since March of 2018 trying to get her credential, and finally got that done within the past week. And it's just been such a challenge, and there's no reason for that. She's directly out of training. She has no baggage. She has nothing. Should be able to do that in less than a week and move her on to plans so she can take care of Texans. So
for 18 months, she was essentially out of network for services.
If she did anything, and she was completely hamstrung by Medicaid, you couldn't bill. They can't bill the patient. So it's just crazy to try to get that money.
You know, we saw this past summer also Blue Cross Blue Shield announced a new policy on emergency room payments that seemed to that TMA took great opposition to, and it was for their HMO plans, and that they announced that they would retrospectively deny payment if they determined that an emergency wasn't truly an emergency, and that people would end up eating the cost of their emergency room care.
Right. Well, we had a meeting with Blue Cross after they did that, and began developing some ideas and some things that we could do that really would safeguard patients, because Dan, the last thing in the world we want to do is see a patient stay home who's in a crisis because they're worried whether the insurance company is going to pay their bill.
Oh, I understand.
And we don't want that to ever happen, and I don't want patients to feel like that's going to happen to them.
We've always held the standard would be the prudent layperson.
Yes. Yeah, if a patient feels like they need to be seen and they need to go to the emergency room, they need to go. And we don't want them to, that should not be withheld. And we're watching closely how Blue Cross handles themselves in this arena. And if they abuse that, we'll do everything we can to shine a bright light on that and be sure that we're dealing appropriately through insurance, the insurance governing system, and also probably some discussion about this during the legislative session.
Yeah, and I know that you had conversations with others from TMA, with the Blue Cross representatives about, if you intend to go through with this, then you've got to make a better effort to adequately reimburse physicians for after-hours care and for telemedicine care.
Yeah, there's no doubt about that. And interesting, you mentioned telemedicine. We still struggle with getting paid anything from plans. Now, Medicare is now paying us for doing things like in nursing homes and things like that. We can use our computer, Skype in, and communicate with the staff there and the patient and evaluate the patient and get paid. But we can't do that with our plans. We've been unable to draw down anything for appropriate telemedicine services.
Well, and I know that you were intimately involved in our legislative efforts on telemedicine last year, and I think we've set a pretty good regulatory scheme for it. And that, number one, it is the practice of medicine, so you have to be licensed. Number two, you are held to the same standard of care as in-person care. But by the same token, plans shouldn't discriminate in payment for a covered service, whether that service is provided to you, by you, to one of your patients, in person or via telemedicine. It is a tool in your toolbox.
Right.
Plans tend to look at this and want to look at the telemedicine as the service, not as the tool. And I think that's changing. Certainly the legislation is help push it in that direction, and we will be back to see if we can correct some of those payment issues.
In the minds of the legislators, that telemedicine was to be offered as a service for all physicians to use, rather than just a company that was selling a product. And because I think at the end of the day, if we're taking care of our patients, be it telemedicine or in person, then it's better for the patient to have one physician or at least a common group that they could work with.
And not to drive your patient away from you
Absolutely.
When it comes to care. We have Dr. Garza on the line from Rio Grande City who has a question about private insurance payments. Dr. Garza, are you with us?
I am. Thank you for taking my call, and thanks for what you guys are doing.
Thank you for joining us.
Me?
Absolutely.
Yeah. So where do I start? Trying to get physicians to rural areas. My wife and I came to Rio Grande City from San Antonio. We went through the credentialing and all, and we had this one insurance company, big, huge insurance company, that wanted to give us 73% of Medicare. We are in an designated underserved area, so we get a Medicare bonus. So we're above.
Yeah. Thank you.
I promise you that I think as long as our Medicaid stays as low as it is, you're going to see insurance companies trying to drive the price down to that Medicaid number. And so that's why we have to get Medicaid up. Otherwise, they're going to keep pushing you down to that level. As long as we take that low payment, they're going to try to drive it to that. And insurance companies are not interested in adequately providing for the physician, nor are they interested in adequately providing for the patient. And their behaviors they're not consistent with that. They've got to do better, and they should be paying adequately, especially for a group that's in an underserved area as you are.
Absolutely. We'll move on a little bit. I'm going to ask Jason to engage with the second poll question that we have this evening. Jason?
Thank you, Dan. Our second poll question for tonight, we would like to know if you currently or will use telemedicine in your practice to care for patients. Please press 1 on your telephone keypad if you do use telemedicine. Press 2 if you do not. Press 3 on your telephone keypad if you plan to. Press 4 if you do not plan to. And press 5 if you're unsure or this isn't applicable to your practice. Back to you, Dan.
Jason, thank you. And while we're waiting for your responses to come in, I'm happy to introduce to all of you Dr. Jason Turk, who is chair of the TMA Council on Legislation. Dr. Turk is a pediatrician from Fort Worth, Texas, and we're delighted to have him with us tonight. Dr. Turk.
Hi, I'm glad to be with you as well. And I'm really honored to serve as the chair of the TMA Council on Legislation. Of course, our busiest time is right now. We're preparing for the 86th Texas Legislature that convenes in January and it's going to finish up in late May. It's going to be a 140-day marathon run at a sprint's pace. And as usual, we're going to see about 7,000 bills or more and resolutions introduced in the session. About one third of these is going to deal in one way or another with health care. Like it or not, the legislature's effect on our practices and our patients is immense. And if you're not at the table, then you are surely on the menu. I assure you that TMA is going to be present and heard from to defend what needs to be defended and advance the cause of our patients and the physicians who care for them. While the Senate and its presiding officer, Lieutenant Governor Dan Patrick, look to return with a supermajority in 2019, the same cannot be said about the House of Representatives. One, the House needs to elect a new speaker, and while that has been the subject of great discussion around the state, it also means we will have new committee chairs, new committee members, and new committee staff to hire. So, while we expect the Senate to begin its work rather quickly, it's going to be some time before the House infrastructure is in place, and that's going to act as a speed bump for at least the first month of session. But at the end of the day, the legislature has only one must-pass bill, which is the state's budget. Typically, that process takes the entire session to iron out, and other bills are often held hostage by one chamber to pass its version of the budget. Maybe this is the year that they're only going to pass one bill, but I certainly would not count on that. Last thing is, I think it's really important to thank the other 17 members representing both primary care and specialty care on the TMA Council on Legislation and the incredible lobby staff of the TMA. This really is a hard-working group, and they spend countless hours looking at and developing the very best approaches to all of our issues. If you have questions about a particular issue, I encourage you to reach out to one of the members of the council. Thanks very much.
Great. Dr. Turk, thank you for joining us tonight. And going back and looking at your responses to the question on telemedicine, I'm always struck that 10% of you say that you're already utilizing telemedicine in your practice, and 22% of you say that you plan to. So I think it's kind of positive moving forward. So, and then moving on in our conversation, I'm always reminded, Dr. Curran, that on our letterhead it says the Texas Medical Association Physicians Caring for Texans. And public health and prevention issues are always a huge part of our agenda. And whether or not the climate is successful or receptive, it doesn't matter. I mean, it's what we do as an association in terms of it's you taking care of your patients and you collectively taking care of the public health needs of the citizens of Texas.
Yeah, public health is an enormous issue, and if you really look at issues like clean water, appropriate sanitation, and vaccinations, they've probably made more difference than anything else that goes on in healthcare. If we're doing those things, then we're making a difference. And probably the thing that we always have to deal with every year is vaccinations. And it seems like Texas is consistently pushing on the vaccination issue and trying to make it fairly easy to opt out. And
we've actually seen a growing number of parents and kids opting out of the vaccines.
If you really look at it, the kids that are coming across the border, even illegally from Mexico, may be better immunized than our own kids, and that's a pretty sad commentary for our state. We need to put a stop to that. And if you look, we had a study done by the Texas Public Health Coalition, and
of which we're a member.
We're a member of that, along with a number of other very, very reputable organizations. And they looked at potential or Texas Republican voters, and we found that 86% of Texas Republican voters, 86%, support current laws requiring children to be immunized to attend public school. And I think that was huge. I'm not sure our legislature really knew it was that strong. So that's a message that we can leverage with our Republican members of the legislature to be sure that we're taking really good care of our kids and being sure they're vaccinated, because, just one outbreak of measles or whooping cough would just be a catastrophe in our state, especially with the number of immunized kids. And I'm comfortable we're going to come back with a bill to clearly define different campuses, the percentage of children that are immunized on different school campuses. We don't need the details about which kid is and which kid isn't, but we need a percentage so that if you have an immunocompromised child, then you can pick the right campus to send that child to. So we got to get that bill passed. It'll be coming back.
Yeah, we had that bill in the last session, and unfortunately did not pass. But we will be back with it. And again, it's not to identify individuals for their immunization, but certainly to let parents know so they can make informed decisions for their kids who may or may not be immunocompromised to just what the vaccination rate is at the school.
Well, appropriate vaccinations, adults included, make an enormous difference in our ability to function. We can work, we're keeping our kids healthy, we're not having to stay home and take care of them. So vaccinations the bang for the buck is huge, and we got to keep it going. Now, Dan, I've just left my practice on Monday afternoon, and as you know, I got here a little late because I was caring for a longtime patient that was a good friend, and
so moving
in the
to
process,
the other end, to the other end,
other end of life, and I think that's what docs do. We take care of coming in and going out sometimes, and this patient was in the process of dying, and I got the privilege of being with the family and spending some extra time with them, and we continue to struggle with advanced directives and appropriate end-of-life care, and we're going to see those issues come up again during this session, and we're going to be well prepared for that. We're going to take those issues on and be sure that physicians and families can make good decisions together and take really good care of our people at the end of life. We know that way too much money frequently is spent in the end of life on futile care, and we want to be careful to make sure that we do that well and do the right thing by these people, by our people. And I think end of life advanced directive issues are going to come back. They do every year, and we have to be prepared, and we're going to be prepared this year to deal with those things.
It is an evergreen issue for us. In some respects, it's Groundhog's Day, but we know the issues are coming back, and they're remarkably sensitive issues for you as physicians. But the politics of the issue just get completely out of hand from time to time, and a lot of misinformation about it.
And we're going to have to really work with our state health department and being sure that we have adequate laboratory services in areas of concern for Zika and other potential infectious diseases that are out there. So we have to be sure our state health department's geared up for all those things. And as you noted, public health just makes a huge difference. It's kind of, I look at it as a white hat issue for us, but we have to continue to stand firm as to its value, and it's huge.
And I think as we look down just the infrastructure of public health and public health response, I think that we have grave concerns about the fraying of that infrastructure as we rise to meet the challenges related to Zika and other infectious diseases, and our communities, do they have the capacity to respond, and what resources are available to them? And I think we have a lot of concerns about the fraying of that public health safety net.
Right. Well, it seems like it's a favorite area to cut things, and we have to put a stop to that. And I also think I want people to know we're going to be back out after Tobacco 21.
Yes.
We want to be sure that we limit the consumption of tobacco if we can, and keeping kids from smoking until later in life is really important if they choose to do so.
And I think we should shout out to San Antonio.
That's right.
It's the first city to pass that local ordinance.
And if docs are out there that want to work with their city in getting that ordinance, let's get her done. Way to go.
Let's move on to a bunch of other issue areas, and let me just jump ahead and talk about the opioid crisis. And we're not West Virginia, but we still have a problem.
Yes.
But we have also seen that physicians respond to information. They respond to information developed by their own national specialty societies, and that generally prescribing has gone down.
Yeah, I think Texas has done a good job of really rearranging how they're prescribing medications. We see our consumption of opioids from physician prescriptions going way down. But Dan, I hope as we deal with this issue that we always keep it in focus. I think one of the great privileges we have as physicians is to relieve pain. It's really a very important part of our job.
Certainly.
No one else has that privilege to relieve pain, and we should do that. It should be done in the right framework and making sure that we administer those medications appropriately and that we do our job properly in this area. But I don't want us to back up from caring for people who need pain relief and not do that because of this. We don't want to get it out of focus because of this opioid crisis can become distorted in such a way our patients.
Sure, and we're seeing some of the ramifications of corporate policies made at by big national corporations that are limiting new prescriptions for pain medicine to no more than 7 days when a physician may normally, for a surgical procedure, write for 10 days. Now, that means that at least for the last 3 days, perhaps that physician's patient is without medication, has to go back for another prescription for a limited time, and then the question is what's appropriate. I know that, and we've seen over the last couple of weeks, both the medical board is weighing in, and I suspect there will be conversations soon with the pharmacy board as to whether or not some of these restrictions that limit patients' availability for legitimate needs are really going to work. But beyond that, this is another red hot issue in the Texas legislature for 2019.
I think absolutely, because it also fits in the corporate practice of medicine. Corporations should not be telling us how to manage our patients, and I think telling us how many pills we can give somebody is just inappropriate. Now, there's a reasonable number, and the prudent physician and reasonable behavior has always been the standard, and it should remain that, and it should be among physicians. Our electronic prescribing and our prescription drug monitoring program that was moved from the Public Safety Department over to the Pharmacy Board, which is a big plus. And I think it's a very functional system, but it's something that we know we can't look up every time we write a prescription. And so we're hoping that, and we've gotten a favorable response from Lieutenant Governors and others, that we ought to be able to generate a piece that goes into the electronic record as those medications are prescribed, or if there's a potential for abuse, that should come into the electronic record, and we shouldn't have to look it up every time.
Just for context, TMA surveys our physician members on a lot of things several times during the course of the year. And one of the surveys that we did this summer was on electronic medical records, and 85% of Texas physicians are using an EMR. And I suspect that within five years or so, that number will be well above 90%, almost 100%. I think we're very rapidly approaching the time when physicians in practice, active practice, have grown up with electronic medical record systems from medical school now through practice. But there are still some folks, because of the finances of EMRs, don't have them. But getting back to opioids and the issues in play in the legislature, last session in 2017, there were moves to mandate that you check the prescription drug monitoring program before writing any prescription for any controlled substance, and that would be a requirement on the prescriber, and it would also be a requirement on the pharmacist. And that bill would have been, the intent was to make that effective September 1, 2017. As we went through the session, it moderated to just 4 drug classes: opioids, benzodiazepines, barbiturates, and carosiprodol, which I'm sure I've mispronounced. And we pushed off the mandated check until 2019, September 1, 2019. As we have worked this issue during the interim, several things have become very apparent. That number one, the idea of electronic integration with your electronic medical record system is doable and doable relatively easily. It's being done in other states. Certainly none as big as Texas, but we can certainly do it here because the software systems that you are using, I think 80% would be, I guess, shovel ready as a way of using it. But that's one thing. And yet still the mandate to check is going to be a disruptive event for patient care if you have to do it manually.
Right.
And so what we've been advocating have basically been three things, and we'll advocate for the next session. Number one, full speed ahead on electronic integration, because that is the way that this technology is going to most benefit physicians and patients in the clinical use of this information. Number two, let's relook at the mandate to check and focus on the most powerful and addictive drugs, which we know they're Schedule II, and they're Schedule II drugs for a reason. The third thing is let us create an advisory group to the Board of Pharmacy comprised of physicians, other prescribers, and pharmacists to help define best practices, to help identify inadequacies in data, inaccuracies in data, and then let's look at the volume of prescriptions and how we integrate. When is it appropriate to integrate the mandatory checking for the Schedules 3, 4, and 5? But trying to take an organized and step-by-step approach to this, and I think we've been moving towards that for the last 2 years.
And I see a lot of other agencies trying to help us with this too. You know, I was in Laredo, and when I was there, one of the DEA agents was at our medical society meeting, and we discussed the drug take-back program.
Yes.
and disposal, and that's worked out really well. And I encourage other groups of physicians to work with their local communities. I know in Athens, our chief of police is working on some projects for take back, and those are all good. The DEA is real positive about that, and those are really good programs, and physicians should support them.
Yeah, we've been advocating that during the interim, during these hearings of the Special House Select Committee on Opioid and Substance Abuse, and some of the data has been rather interesting, because you know and I know that people stash the unused parts of their pain meds, and they save them for later. But here's how it plays out. We've seen the numbers that 68% of individuals' initial involvement with a prescription pain medication is not from a prescription they received themselves. It's from somebody sharing something with them or having access to something that they shouldn't have. And I think that speaks extraordinarily strongly for the need for more regular and more organized and more available take-back programs.
Yeah, I think we're going to see those moving out.
I think without
really
a doubt,
well. Really
we're
well.
certainly going to be advocating for it. Let's move back into the Texas Medical Board and licensure issues, because it's Groundhog's Day all over again for us, because we had the sunset bill for the medical board last year. It was held hostage. The hostage was executed. It came back in a special session with a 2-year extension, not a 12-year extension, and we're right back where we are with the medical board.
I know that issue is going to come up quick. We met with the Lieutenant Governor about it. He pretty much assured us that would be one of the first priorities. And I've been really fortunate. My senator, who I have a great relationship with, and I encourage all docs out there to make those relationships in your own network and make sure that your physicians are that you're building a relationship with your legislators, so you can they'll help you. They want to. And my senator's pretty much agreed. He's the vice chair of the Sunset Commission,
right.
And so he's pretty much agreed to kind of carry that bill forward, and he and the Lieutenant Governor have a good relationship. So I anticipate that moving pretty quickly, and we're going to ask for a lot more than I think actually a couple of years more than the 12 years, maybe 14 this time, because the fewer times the Medical Practice Act is open, the better off we are. You know, because everybody wants to do what we do, Dan. You know that, and you just see nurse practitioners and others that want the independent practice of medicine, and we're going to stand firm against that again this year. We think team-based care is the way to go, and that certainly enjoy the relationship with good nurse practitioners and good PAs that we work together with to provide care, but the physician's always the leader of that team.
You know, we worked on these issues in 2013 and actually had an agreed-to legislation with nurse practitioners and PAs to completely rewrite the regulatory scheme of delegation and supervision of prescribing privileges. But as you recall, we went into the session and we locked a bunch of doctors in the TMA building on a hot August day and said, tell us what your core principle is. And of course, it didn't take you all long to come to that. And basically, that core principle is that independent diagnosing and prescribing is the practice of medicine. A physician can delegate but must supervise because that physician is ultimately accountable. And so having established that core principle, and that principle does not change. That's been constant with us all this time. And that's when we articulated it the best, was 2013. That if there are problems, if there are ways we can improve a more collaborative and communicative relationship for the betterment of patient care, and it is always about patient care and improving the team concept of providing care, then we're open to consideration. But our core principle is we can't violate and will not violate. And so we will have, once again, another round of these considerations. And it's not just nurse practitioners. I know optometrists want to do LASIK surgery. Everybody else wants to do what you do without doing what you've done, and that's go to medical school.
Yeah, and, you know, I'm convinced, Dan, that we'll be dealing with this whenever my great-grandkids are trying to practice medicine. It'll go on for a long time, and we just have to be vigilant in being sure we keep our patients and our state safe, and to make sure that physicians are leading the team.
Sure, and it is intentionally set up that way because it is essentially the one with the most education gets to be captain of the team.
That's
and right
correct.
now,
that's
you.
That's correct.
Well, you know, there are a ton of other issues I guess we could go over, but you know, we really are kind of out of time.
Right.
I will tell you, this is the fifth discussion we've done, and I want to thank you for being here and being available for the members of the TMA. And I know that we call on you for a lot, and we'll be calling on you for more come January.
Well, I love the experience. It's just been great to visit with Texas physicians, and we've gotten great feedback, and it's always good to be together and to share our vision of where we're going and how we're going to get things accomplished and provide better health care for our people.
Thank you, Dr. Curran. It's been a pleasure being with you these five nights. And for all of the doctors who have joined us on the call, thank you for hanging with us. We hope you found this to be an interesting program and a conversation. And there are a couple of things that I need to tell you. If you are still on hold, or if you have a question or comment that wasn't addressed, call the TMA Knowledge Center at 1-800-880-7955, or email us at knowledge, KNOWLEDGE, at texmed.org. Thank you again for joining us tonight. Dr. Curran, thank you. Dr. Fite and Dr. Turk and Dr. Rogers, we appreciate you as well, and thank you for joining with us. You will have the CME polling question, and I believe Jason will pitch that to you, and he will give you the options for you to answer on your phone, and I've already given you the answers.
Thank you so much, Dan. Folks, again, you can answer these by pressing numbers on your telephone keypad. We'd like to know, are you going to implement any new strategies based on what you learned in this call? And if so, which? Press 1 for attend TMA's first Tuesdays at the Capitol, the lobby days for the session that starts in January of 2019. Press 2 on your telephone keypad for you'll be signing up for TMA Legislative News Hotline email reports. Press 3 if you're going to be responding to TMA legislative action alerts. Press 4 for you're planning on either writing, calling, or speaking to your legislator. And press 5 if you're going to do more than one of the above. We appreciate everyone taking the time to join us this evening and answer the poll questions as well as participate in our discussion. This has been a live telephone town hall meeting with the Texas Medical Association. Thank you again, everyone, for joining us. Good night.